Thank you. Well, first, we want to thank Supernus Pharmaceuticals for sponsoring these programs, the monthly Take Charge Live that we do, as well as the pedal posse. It's an indoor cycling class that's twice a month that they help support. So if our friends from Supernus, Ariane and Brandon are listening, hello, thanks for all your support. I'm Sanjay Iyer. I'm a movement disorders neurologist here at Memory and Movement Charlotte, and it's always fun to talk about different aspects of Parkinson's disease. And this month we thought we'd talk about something a little bit different. We always focus on tremors and walking and balance and all these things, but the non-motor symptoms, when we think about it, can be very challenging for patients and caregivers, and very challenging for providers to treat. So when I think about Parkinson's, I think about two buckets. I think about symptoms that can impact the quality of your movement, and whether that's a tremor, whether that's slowness, whether that's stiffness, whether that's falling. But then there's a whole host of invisible symptoms, as we call them, or non-motor symptoms that are just as important to understand. And I remember early in my career, I was so fixated on how much was someone's hand shaking, and I had to increase their medicine to fix that. And I often would miss the boat on what's really disabling for this family. It's not the tremor, it's their depression or their apathy or whatever else those things are. So over the years, I'd like to think we've gotten better at asking some of those questions, because a lot of the non-motor symptoms are such that patients and caregivers aren't always comfortable in talking about them. And so how do we create the environment so that they are more comfortable? How do we maybe ask better questions to sort of solicit some of that information? But when we think about non-motor symptoms, the most common ones reported, and this is from a very systemic review of 70 different studies, but 90% of patients reported hyposmia, which is losing their sense of smell, which by itself may not sound bad. However, smell is so connected to taste, and when people can't smell and they can't taste, they don't eat and they lose weight. And there are a lot of things that can start to happen. So the sense of smell is actually very important. 81% of patients reported constipation. 60% reported anxiety, 60% reported apathy, and those are two things that Tom's going to educate us about in just a few minutes. 40% reported hallucinations or delusions. This is usually later in the course of Parkinson's, and again, Nicole's going to talk about those in greater detail. And 35% reported depression. Interestingly, 69% of the patients that were queried reported that their non-motor symptoms were more disabling than their movement-related symptoms. So that tells us why is it so important to talk about these things, because patients are saying, this is what bothers me the most. And among the most disabling non-motor symptoms that patients reported were depression and anxiety, which were tied for number one. Fatigue was a close second. And sleep disorders was a third. Now, Parkinson's can wreck sleep in so many different ways. Some people just develop insomnia. They can't fall asleep. Other people fall asleep fine, but they wake up after a few hours in the middle of the night. The bladder is a big culprit. People have to get up and go to the bathroom a lot, so that can be part of it. Other people have a condition called REM behavior disorder, where they have very vivid dreams, and if they act them out, their body is free to move. And some people, it can become very even violent. They're kicking, punching, and screaming in their sleep, which can be very disruptive to their care partners and other family members. But so sleep is a big one. Now, from the vantage of clinicians, studies have shown what clinicians feel are the most difficult non-motor symptoms to treat, or perhaps most challenging. And so number one was the fluctuations in blood pressure. So some people have what we call orthostatic hypotension, where the blood pressure drops precipitously when they stand up. Other people fluctuate all throughout the day. They can shoot up to 200. They can drop down into the 60s. And so blood pressure fluctuations can be really tricky to treat. Apathy was the second one listed by clinicians as hardest to treat. And then the third, hallucinations and delusions. So hence why we're focusing on this today. And one question came up as to when do the non-motor symptoms emerge? So interestingly, constipation and REM behavior disorder can actually begin decades before the physical symptoms ever show up. Some people in their 20s or 30s develop REM behavior disorder, and it could be a risk factor for ultimately developing Parkinson's. Constipation is another one. Loss of sense of smell and mood disturbances have been shown to appear 2 to 10 years before the physical symptoms ever begin, sort of the preclinical phase, such that a friend of mine who's a really astute psychiatrist, when he has patients with depression that he just cannot make a dent in, he's asked me in the past to see those patients and examine them and see if there's any sign of possible Parkinson's, because their depression can be so hard to treat until you get them on the dopamine replacement therapy. And then finally, some of the non-motor symptoms that usually show up after the physical symptoms show up tend to be insomnia is one, impulse control disorder is another, where people develop a strong interest in gambling or hypersexual activity or compulsive eating, behaviors they can't control. And it's usually more related to the treatments of Parkinson's. The dopamine replacement therapies can cause some of those things. As disease progresses, we see more issues with cognitive impairment and excessive daytime sleepiness. So that's sort of the quick overview of non-motor symptoms. So Tom, I was hoping that you'd be able to talk to us a little bit about apathy, depression, and anxiety. So what are they and how do people describe them?
Happy to. I want to first just introduce myself real quick. I'm Tom Christy. I'm a PA working directly with Dr. Iyer. I had some experience in behavioral health before I came to memory and movement. I did a psychiatric fellowship and an academic doctorate in it. So I'm happy to talk about those things. As Dr. Iyer mentioned, obviously patients often come in looking for assistance with their motor symptoms, but some of the most bothersome are things like apathy, depression, and anxiety. And a lot of people ask, well, what is apathy? I think most people kind of have an idea of what depression and anxiety are. But then caregivers come in and say, my loved one just doesn't want to do anything. They can't get out, and they just don't have any motivation. And that is essentially what apathy is. And sometimes people think that it's just a response to the diagnosis, but it's much more than that. So is anxiety and depression. They're not just, well, I got diagnosed with this disease and now I feel this way. It's because all of these, all anxiety, depression, and apathy are physical symptoms as a result of the pathophysiology of the disease. So when I think of apathy, it's loss of motivation or initiative. It's not laziness, and it's not a choice. It's someone who's sick. And then depression, and Dr. I mentioned that apathy is somewhere between 17 and 70% of patients with Parkinson's, so a wide range. Depression, the struggle with depression is that it often mimics the symptoms of Parkinson's, right? So if someone feels like they have reduced enjoyment in things they typically would have enjoyed doing before, sleep, appetite changes. Sometimes their face is just less expressive, right? And so this can mimic the same symptoms of Parkinson's. And anxiety, I think of anxiety, it's this worry that's inappropriate to the situation typically, or it can be appropriate to the situation, but it's people can panic. They can just feel like they cannot help but worry, and all of those things are, as you can imagine, are at least as bothersome to many people as the motor symptoms, and they're also sometimes hard to control.
Tell me, when people present with apathy, depression, and anxiety, all these things, what's the workup? What's the metabolic workup? Do you order labs? Do you look at, are there meds that might cause some of those problems?
Yeah, good question. I do think it's important to acknowledge before I move forward that apathy and depression aren't necessarily the same thing. You can, if you have depression, you can think of there's a thing called anhedonia, which means you have less enjoyment in things you used to enjoy doing, and apathy is just don't feel much motivation to do anything, and they're both problems with Parkinson's. But just like in a behavioral health emergency department or a psychiatrist's office, if someone comes in and says, I'm just feeling depressed, we don't want to just assume that it's only caused by a psychiatric illness. We want to rule out other causes first. And so the first things we typically look for, if you have a new patient appointment or someone who I just met for the first time and this is a new symptom for them, I want to rule out several things. Number one is thyroid disease, because having low thyroid can certainly cause you to feel be depressed, less motivated. People often ask why we're checking things like vitamin B12 and folate deficiency, and it's because carbidopa levodopa can reduce that vitamin B12, which can certainly make you feel more depressed. Low vitamin D is something I check all the time. Dr. I mentioned that sleep is something that people with Parkinson's struggle with a lot. And if you have sleep apnea, that can really wreck your life in many ways. Increase your blood pressure, make it so you're not sleeping well at night, make your Parkinson's symptoms feel worse. Urinary tract infections, all these things that we want to rule out first. Also, there's Parkinson's specific causes. I think it's easy to think that people just have depression and there's not much to do about it other than maybe going to antidepressants, but making sure that you're checking when they're experiencing these symptoms. If it's when they're having really off episodes, then we need to make sure we're optimizing their dopamine levels, right? Sometimes people don't really feel physical symptoms of their dopamine being low, but they feel anxious, or they feel less motivation, they feel depressed. Sometimes people are taking some dopamine agonist medications inconsistently, and when they are feeling withdrawals or depressed, it's because they're experiencing dopamine withdrawals. Also, many other medications, whether it's Benadryl, some of the other medications that we try to use to help extend the time of dopamine, can certainly contribute to some of these symptoms. And then, oddly enough, medications like SSRIs that people commonly heard about for antidepressants can actually worsen apathy too. So, really important to make sure that we're doing a thorough medication evaluation in addition to checking labs to make sure that we're not potentially causing some of these issues.
From a treatment standpoint with Parkinson's, there is one medication that we use called amantadine, and amantadine can often cause or worsen depression. So we have to be mindful of those things when we start seeing it. And is there a role to perhaps try to come off of one of those medications? Tell me about lifestyle approaches and medication treatment. How do you kind of have that conversation with families?
Sure. I would say that one thing we always try to emphasize is that exercise is the only thing we know of that slows down Parkinson's disease. And my philosophy is to use levodopa and other medications to help improve our motor symptoms so that people can exercise. And if you're able to exercise, that's going to likely help improve your mood. But the first step is optimizing your dopamine therapy. So oftentimes we see that when people take oral levodopa therapies, if they're immediate release, then we see lots of ups and downs and their peaks and valleys of their dopamine. And that can cause a lot of apathy, depression, anxiety, ups and downs. And so if we can get them on statement medication at a consistent time, or include some extended release dopamine, people who are on the pumps that we offer, those can certainly help with reducing the ups and downs. Sometimes we use some medication extenders that flatten the ups and downs of levodopa, but optimizing our medication regimen is first. From there, lifestyle factors, I would say first of all would be exercise. We know that exercise helps every aspect of our lives. It certainly helps people sleep, helps improve your mood, and then often we find that that motivation comes after we start, right? So if you wait for to feel motivated to exercise, you're probably never going to get started. There are some other things like Tai Chi and yoga, even chair yoga can certainly help. Exercise doesn't have to be something where you go and work out for 2 hours straight, and by the end you're drenched in sweat. It's something that gets your heart rate up. It's something that's different than what you're doing throughout your typical day. It's something that is added to get your heart rate up, ideally build your muscles up, and try to release some natural dopamine too. The third thing I would say is, well, actually, while we're talking about lifestyle factors, therapy can certainly be helpful. I would say that therapy would be helpful for anybody. Social engagement, support groups, if you're feeling lonely, if someone is overly tired, sad, sick, lonely, afraid, all those things, it's going to make your Parkinson's symptoms worse and likely worsen your mood. So having social engagement is certainly incredibly important. And then trying to optimize your sleep. All those factors can certainly help improve your sleep, but sleep hygiene, making sure that you're not drinking caffeine after 2 p.m. And talking with us if you need help with establishing a good sleep regimen. And lastly, medications can certainly help. We just have to be careful that they're not the medications that could be worsening the symptoms or worsening the apathy in the first place.
Yeah, I think final question for you, Tom, before we can sort of transition over is, what is GeneSight?
One of my favorite tools that we have. I feel like coming from a behavioral health background, one of the struggles that I often had was even if I have several medications that might be helpful for anxiety or depression, we don't always know if they're a good fit for each patient. There might be 5 or 6 medications that I would consider, and then you can spend all this time trying to figure out which one would be the best for this person based off of their side effects or whatever their symptoms are. But in the end, it still might not work. And GeneSight is helpful because it helps look at your specific genetics, the enzymes in your liver primarily, but also some other pathways that antidepressants can use. It's a simple cheek swab. Most, not shouldn't say most, but many insurances are covering it these days. We send it in, and it sends us back a report in a few days, and it gives us 3 columns: green, yellow, and red. Green is no known metabolic problems or pathway problems. Yellow may have 1 or 2, and red means maybe avoid because it's going to be hard to overcome those problems. It really helps guide the treatments that we use because often with antidepressants, it takes 6 to 8 weeks to notice a full difference. And when someone is feeling really depressed, really anxious, that's a long time to wait to decide that something's not going to work. It doesn't guarantee it's going to be a great response. So we also have to be very careful to make sure that other medications aren't impeding the metabolism of these medications or making you metabolize them too quickly. But oftentimes we'll see somebody who has pretty significant side effects from a medication and feel like it just doesn't work. And then we do the GeneSight and it shows us. GeneSight can tell us how, if you will likely metabolize a medication at the appropriate speed, whether you'll metabolize it too slowly, which will mean it will build up in your body too much and likely cause side effects, or too quickly, which would mean that even at high doses, the medication likely won't work because you'll just metabolize it too quickly. So GeneSight, there are several other genetic testing modalities. We have found that GeneSight fits our practice for what we're looking to do, but we can interpret anyone. If you bring it in from another office, we can figure it out.
It was nice because in the old days it was trial and error, and I'm depressed, so here, try this, and people come back in several weeks and I feel worse, and maybe it's because it's a side effect or maybe because it was the wrong medicine. But now we actually have a more targeted way to more quickly get to the right answer and help people in a quicker regard. But as we sort of shift gears, whether it's apathy, depression, and anxiety, or whether it's hallucinations, delusions, Nicole, in your role as a patient educator with Acadia, how do you counsel patients? How do you counsel caregivers on how to start the conversation talking about things that are really potentially uncomfortable?
So hallucinations and delusions, nobody likes to talk about it. It already has a hard word, right? Nobody wants to talk about hallucinating. But the first thing what we do is we talk about how this has a diagnosis. It's called Parkinson's disease psychosis. So you have Parkinson's disease, PD, and then if you are having hallucinations and delusions, it's also called PDP, Parkinson's disease psychosis. It is a symptom of the disease. So I try to make sure that we all understand that this is not a taboo subject. More than around 50% of people with Parkinson's disease can develop this. It's a lot more common than people think, but nobody likes to talk about it. So we need to start talking about it. We need to get comfortable with being a little bit uncomfortable sometimes, especially when you're with your providers. If we keep things bottled in, it will never get taken care of. A lot of people don't want to tell their care partners or their doctors, their loved ones, because they don't want someone to think that they're going, and I hate this word, but crazy. You're not crazy. It's a symptom of the disease. So that is what I first do. I try to get us all comfortable with what this is and why it happens. It's part of the disease. And then we start to talk about, okay, what's a hallucination? You may sense something behind you, a presence. That happens to me and I don't have PD, so take it with a grain of salt or talk to your providers about it. They can help you. But if you are constantly looking over your shoulder and maybe you see a coat rack and every time you look at it, you think it's a person, that could be headed towards the more hallucination side of it. You can also hallucinate smells. If you start to smell lemons and you haven't smelled in 10 years, that's a hallucination. Taste, very similar to what we were talking about. If you haven't tasted anything for 10 or 20 years and all of a sudden you start to taste ash or lemon, anything. It really could be anything. No one has ever told me that it's cookies, but in my head, I like to imagine it would be a lovely taste, but I don't know if that's true. So if all of a sudden you're tasting things or something you're tasting like coffee tastes off, that can also be a hallucination. Sounds, I could hear the doorbell over and again, or a TV may be off or muted, but you can hear like a white noise. So sounds can very much be an hallucination. A lot of the stuff that we say, oh, that's nothing. It is something. That's how we start.
And I think it's important to know that, Parkinson's by itself can cause these problems, but so can a lot of the medicines we use to treat them. And so, as we were talking about earlier, certain medications like the dopamine agonists, like, pramipexole and ropinirole and the rotigotine patch, and they are notorious for causing hallucinations in elderly people. Amantadine can cause hallucinations in a lot of people. So I think, as Nicole said, I think it's very important for people to realize if you do see something that no one else is seeing, don't automatically assume you're losing your mind. Very likely it could be your doctor's fault because we have no medications that might cause it. So again, I think just being comfortable asking or talking about them is important because there's often a very simple solution. Sometimes, as you said, sometimes patients won't even share with their care partners that they're having these issues. How can care partners recognize these symptoms if they're not sharing or saying that this is what's happening?
Communication, right? Everybody has to communicate. And what do we always complain about? We just don't communicate well sometimes, even with your own partners. So it all starts with communication. If I notice that Papa is constantly getting up and out of his chair all the time and going to the front door, I might say, oh, he's just getting his movement in today. Way to go for exercise. But if I really sat down and talked to him, it was because he was hearing the doorbell all the time. So any type of behavior change, and this is definitely more of the clinical side, any type of behavior change, anytime your partner is acting odd, maybe when y'all are walking down the street, you notice that maybe their balance is a little bit different than usual. We all know we're familiar with that gait instability. But if you notice when you're walking over cracks, if they're a little hesitant, there could be something going on there. Sometimes with a hallucination, you may see a belt on the ground. It may look like a snake, and that is very scary to me. I'm going to run away screaming. I hope someone says, are you okay? So we, as care partners, family members, and friends, we have to start asking questions.
I think the biggest challenge with these, as you said, it can be so taboo. And so either the patients don't want to talk about them, or sometimes even the care partners don't want to bring it up because they're trying to protect their loved one. But again, the key is you got to let us know, because there's a lot of ways to approach it. So people who are reluctant to talk about it, what do you tell them? I mean, how do you encourage them to open up and talk to their providers? Or
So what I say is, you are still you, right? My name is Nicole. You are still you. You are not your disease. Your disease does not define you. We're in 2026. We use people first language. You are a person first. So biggest part about this is I want everyone to be educated, to know what the symptoms can be, and to be an advocate. Because y'all are out there, you're in the community, you're going to rock steady classes, or maybe you're joining a young onset group, or maybe you're at church or wherever you are, even the grocery store, right? I meet people all the time. And just by you being educated about it, whether you're a care partner, a loved one, or a patient, you can take all of this into your own hands. And the more educated you are, the more likely you are to advocate for yourself. It is so important, because no one's going to stop you in that doctor's office right before you leave and say, oh, wait. Are you sure everything's okay? So they are going to do that, right? And maybe here they do, because y'all have such lovely long appointments, but that's not always the case. So I do like to encourage people, even if you have to make a Post-it note, if you're having a hard time writing, I don't know, put a big piece of paper in your bag, tape it to the wall, set an alarm on your phone that says, I have to talk to doctor. Like, you can't be silent. And so when you are silent, you're going to suffer longer. And the more silent you are, the less other people in your community are going to learn about this.
And one of the questions that comes up is, well, if non-motor symptoms are so common, why is there's such little focus on it in the appointments? And part of it is that sometimes people don't want to share them. But I think the bigger reality, the problem in most practices, and you used to be in operations, that the drill. I mean, providers are being pushed to see more and more patients every day and less time, and you can barely get through their tremor and their walking before it's time to move on to the next room. And so part of it is just not having time, and that's where if people prep for their appointments and come to the appointments with some notes, write down your questions, write down what are the top 3 things we absolutely have to get through in this visit. And it may not be my tremor, it may be other things, but I think that helps kind of keep the appointments on track and help guide us. And often when my nurse goes to get people into the room and get them set up, she'll ask them, what are the top few things you want to talk to Dr. Iyer about today? And so she'll come and let me know and say, hey, don't worry about their tremor. They're really focused on this other stuff today. And so we'll be able to devote the appropriate time to those topics. So tell me, beyond just the patient support, how do you support caregivers that come to you or call you and say, how do I manage these things? What do I do? Who do I go to?
So for care partners, caregivers, family members, I know y'all have heard this, you cannot pour from an empty cup. I mean, that is beyond true. You have to take care of yourself so you can take care of your loved one. Attending the appointments, if your loved one will let you, is a great start, because it would be lovely if, as the care partner, as a family member, y'all had a rapport with the doctor or with the staff. Because sometimes I may recognize something that grandpa's doing or acting, and he is not going to admit to it. But if I'm not in those appointments with him, no one's going to say anything. So being involved in the care is a great way, because someone needs to hear what you have to say, even if the person that has experienced it, a little bit like what we call a delusion. So with the hallucinations, there can be delusions as well, not always. So even though everyone is telling you it's not true, you still believe it. That is a really important thing, to have a care partner right there that is able to talk and represent yourself. Even if I keep telling you no one's stealing your money, look, here's all of your money. But you look at it and you say, I see my money, and you're still stealing it. So that is a huge part. But as a care partner, go to the support groups, go to the exercise classes, because you know why? Everybody's there. Most people are there with the partner, and the partners end up sitting outside. And usually that's where I make a lot of friends. Go into the doctor's offices. Even if someone doesn't want you to be in the appointment, you can meet other friends in the lobby. Reach out, see if there are social workers or behavioral health counselors. You absolutely have to take care of yourself as well.
And delusions are tricky. I mean, delusions essentially are a fixed false belief. And the challenge with being a care partner or a caregiver in a situation where people have delusions is that often they are the target of the delusion, and it's an issue of, oh, my wife is trying to poison me. Well, maybe she is, but more often than not, she's probably not. My wife's trying to poison me, so I'm not going to eat anything she cooks anymore. I'm only going to order takeout. Or more commonly is, my spouse is, having an affair, and that's probably the most common one. Or, I saw the way my husband was looking at that physical therapist, that he must be having an affair. And so it can be really challenging when not only are you trying to help your loved one, but you become the target of what the delusion is. So that can be really tricky. But well, Tom, tell me something in terms of hallucinations and delusions. How do you work that up? I mean, are there labs you check? Or are there medicines that you look at saying, well, I think this may be causing a problem?
Sure. So when I think of hallucinations and delusions, I mean, the number one thing we talked about a little bit before was optimizing your dopamine therapy, right? Because it's really often people think that, well, if I'm having issues with Parkinson's, then I need to increase my levodopa, right? I need to increase my dopamine, and that's often the opposite of what you would need to do. So if someone has other signs that they already have too much dopamine, right? They have dyskinesia or wiggly movements, or they are having feeling dizzy when they stand up that they didn't have before, and then they're also starting to hallucinate. Well, it's likely that we need to adjust some of those medications first. Those are the big things, especially like you said, the pramipexole can certainly be part of it. Other medications that can cause you to start hallucinate are things like Benadryl, and certainly the amantadine, things like that can make it worse. So unfortunately, with Parkinson's, even though just like Nicole said, it's certainly part of the disease, I would say at least as often, especially if it's earlier on in the Parkinson's disease, it's caused by us, it's caused by healthcare providers. So hopefully that helps reduce some stigma as well, because it's not that it's ever the patient's fault, but it often is caused by medications instead. So,
and if it's not our fault, it's usually a UTI, urinary tract infection.
Also true.
When we get the phone call that, oh my gosh, my husband's seeing things, or he's really confused, not sure what's going on. He was fine yesterday. When it's that abrupt of a change, it's almost always a metabolic problem like an infection, and UTIs are the most common thing. So some of you may have experienced, if you're ever noticing any challenge, we order a lot of blood work and a lot of urinalysis because you often find the reason for it. So one question we have as it relates to hallucinations is that we see, I've talked to a lot of care partners where they spend an inordinate amount of time trying to convince their loved one that man over there is not real. I don't see that man. I know you think you see that man. He's not real. So end the story. But that often creates a scenario where people are butting heads, and as real as it is to one individual and as real as it's not to the other individual, it can cause a lot of turmoil. And so, how do you counsel caregivers to respond to is that person over there real or not?
I have a lot of experience talking with patients, and I can tell you it is real to them. I mean, it is absolutely just like the doctor's saying, it's as real as to them as it is not real to you. And that's kind of a hard concept. There are a few things that we can do first, right? Like, let's think about what's going on at the home. I know this sounds weird, but a lot of people do it. Christmas lights can be fun. There are some things that you can do. It's always like an entryway, or what is it called where you put your hats? Come on, like a hat tree, a clothes tree where you put your umbrellas. Usually it can be something like that maybe if we have better lighting, it'll be a little bit easier, more easy to identify. So that is something you can say, oh, well, let's turn the lights on. So do you still see him? Is there still someone there? And yeah, there probably is, honestly. It doesn't always work. Every now and then the dim lighting can have something to do with it. But you have to listen to what they're saying. You have to support them. And I'm not saying like humor them, but you have to really support them. Who is it? Is it someone you know? Are they talking? What's going? Give more information. But as a care partner and loved one, write it down. Call the nurse's line. Let them know this is what's happened, because the docs are going to want to know the progression. Pay attention. Did something interesting happen that day? Did you have a horrible night's sleep? All of these things is what happens in your everyday activities can impact that. But as a care partner, validate, validate, validate. You have to say, oh, I hope you're not going to tell me something different.
No.
You have to understand and say, okay, I know that you see children in the backyard. I understand you see them. I do want to let you know they're not there. And then you say, oh, okay, I'm having a hallucination. But when you start to come inside and make sandwiches for the kids in the backyard, and I say, there are no kids in the backyard, and you say, well, I know that, but it's going to be dinner time. I need to make those sandwiches. That's when it's starting to impact your everyday life. Those activities of daily living, it is impacting you. So when there are changes in your everyday life, and I can't sit and have a reasonable conversation, you have got to tell your doctor. Even before then, tell your provider.
Yeah, I agree with most of that. No one has, patients don't have a hard time acknowledging that the movement symptoms are from Parkinson's. And so acknowledging and saying, I understand that you see those hallucinations. I don't see them. It sounds like it's one of those Parkinson's hallucinations. Acknowledging that it's a disease process, right? It's not that they are developing, some other disease, right? It's part of the Parkinson's process, and I think by acknowledging it, it causes less conflict. And they know, if their care partner doesn't have Parkinson's, well, it would make sense that they don't see it, right? And oftentimes our patients have hallucinations that are just not bothersome to them, and so it can. If there's, they see an old friend, the most common hallucinations in Parkinson's are small children and animals. And if if you see your childhood dog running around outside, and you can kind of acknowledge that it's probably not real, but I still see it, and it doesn't bother you, then I would be very hesitant to put that person on medication that can have its own side effects to treat something that's not a problem.
Really, what are bothersome hallucinations and what are non-bothersome, and that's really the key. If it's a cute little cat sitting on the kitchen table, it's one thing. But if there are people in your yard with guns, it's how big of a problem is it? Because the good news is there are treatments, and we commonly prescribe medications to treat those things.
Well, I would hate for it to impact your everyday life. So if you trip over that cute furry little cat and you hurt yourself and you become 1 less degree independent, I think that at that point, we've obviously already had a problem. So that's why I encourage, tell the doctor, sorry to put it all on y'all, but let them know so they can document it. And then they can say, okay, so you're hallucinating, you hear the doorbell, and you only hallucinated at home, right? Not when I'm driving, not at the doctor's office, only at home. Okay, are there any barriers around when you're getting up to go to the door? Is that a problem for mobility wise? If it is, I'm worried you're going to trip. I'm worried you're going to fall. So when it is impacting your everyday life, that is when I encourage, obviously in the very beginning, but as well as when it's impacting your everyday life, you're getting up and down and you may fall, that's a problem.
Some simple things I've learned from some of my patients when they think there's a man sitting in the chair over here. What are simple ways for them to do a quick check? You mentioned the Christmas lights. So one of my patients keeps a flashlight and turns the flashlight on, and if the beam goes right through the person, he knows it's not real. Another one, she keeps a small little throw pillow, and so she'll just toss the pillow onto the chair, and she figures if someone's really there, they'll give it back to her. But if not, it's not going to happen. Or people do the same thing with a small, throw blanket or something like that. So there are ways to sort of teach patients how to check it themselves, as opposed to having your partner having to convince you it's not or go and do something. I think as you alluded to, I think the worst thing that care partners can do is start playing into the hallucinations. And I'm going to go get the cookies for all the children that are here. So you don't want to get involved in the hallucinations, but but you also don't want to make them feel as if it's not real, because it's real to them. It's maybe not real to you, but using terms like, I think it's one of those Parkinson's images that you can see that I can't, sort of take some of the negativity out of it. So yeah, but that's the way I think it's important to have this discussion, is that, everyone's on the same team. We're all here to help. Tell me a little bit about your sort of advocacy work and in terms of your role at Acadia and kind of patient education in general, the things that you focus on.
So again, as a patient educator, my job is actually to be here and talking to y'all. I actually don't often talk to healthcare providers. My job is to make sure everybody that has this diagnosis, if I can find them and talk with them, we are going to talk about education and advocacy. There's the World's Parkinson's Conference, and oh my goodness, you guys live in the Carolinas. The Parkinson's Association of the Carolinas is amazing. I am coming up here all the time. I live in Birmingham, Alabama. I may as well live in Charlotte. There is always something to do. I was talking to Suzanne at Rock Study at the JCC today, and I said, okay, what about rock climbing? Has that gotten big here? What about ping pong for Parkinson's? So there's all these new things and all of these activities that are coming up, which I love about these activities is the advocacy is there. You're going to learn something about your disease. Or the social integration that we talked about. Even just going and standing in the room, you're not alone. You're with other people. You're doing an activity. And then a bonus, it could be exercise, exercise, exercise. So part of that is to be involved in the group. Go to the walks. Talk to the social workers, talk to the front desk people, talk to everyone in the office. Hey, do you know of an event that's happening? Y'all's website is really great. This website has wonderful resources to look and see what's going on in your area and attend these types of events. The more you learn, the more you can take charge in your healthcare and you can advocate for yourself and then you can educate others.
That's well said. I think we're probably at that point where we probably need to move into the question and answers.
If anyone on camera or in the room has a question, you'd like to ask it in your own voice, you're welcome to. Or you can put it in the chat as one person already has, so you can start with that one. Somebody wrote, I'm newly diagnosed with Parkinson's and my doctor prescribed Sinemet to address my physical symptoms. How does that work?
Want me to take that? Or you?
All you.
So the fundamental problem in Parkinson's is that there's not enough dopamine. Dopamine is the neurotransmitter that helps modulate movement. And so Sinemet, which is carbidopa, levodopa, it's just simply a way of replacing that dopamine. It's geared to help make movement more fluid, more natural, less stiff, less slow, help people pick their feet up more easily, dampen tremors. It's not a cure for the disease, but it treats the symptoms pretty well. So that's kind of the long and short about Sinemet.
Okay. Any other questions?
I would say about Sinemet that people commonly refer to that as the standard immediate release version of carbidopa levodopa. It's kind of used colloquially as Sinemet. And oftentimes people do get started on the immediate release initially, but then there are so many different formulations that we use, and carbidopa levodopa is often the foundation of our treatment. But just because if someone feels like Sinemet doesn't work for them necessarily, there's that dose, that timing, that formulation doesn't work for you, but we can probably find something that does.
Anybody else?
But I think the interesting thing is that, as a movement disorder specialist, I think I spend much more of my time on non-movement related symptoms. That just tells us how much things have evolved in just the understanding of Parkinson's and all the problems it can cause.
Oh, sorry. There's a lot of people. I was just curious if anybody that's listening was is anybody in the Rock Study groups in Charlotte, or I don't know how far your reach is. If there's anywhere else I can go, invite me. You just put it in the chat, because that's part of my job, is to be in the community, to learn about y'all's community and how I can support you. So please, if anybody's paying attention, invite me to your classes. I'd love to come. Oh, maybe someone's.
If anybody wants to get in touch with Nicole after the session, you can send an email to us and we'll put you in touch. How do you determine when to use extended release? And we have another question about exercise. So why don't we do the extended release first?
So the extended release, so generally, the times I'll look at the extended release preparations are when the immediate release, the Cinemed as we call it, if the effect doesn't last as long as it needs to, and we generally start out taking it 3 times a day, but if it starts getting to 4 or 5 times because it's just lasting shorter and shorter, that can be hard to keep up with. So extended release, you don't have to take it as often, theoretically. The other time we look at extended release preparations are when people start having side effects to the immediate release. Typically it's how quickly does your dopamine level rise after you take the medication really drives the side effects. So whether it's nausea, sleepiness, some people develop the involuntary movements, the dyskinesia from levodopa, and it's really how quickly are you absorbing it. So the longer acting, slower releasing forms tend to cause less of those problems.
Is that when you would suggest the pump to a patient if they're?
After we've tried a couple of the oral extended releases and other things, that's generally when we would kind of get toward the conversation around a pump.
Oh, more questions. What type of exercise is best for Parkinson's? More than once a day, aerobic exercise, some other kind of exercise?
I was thinking volleyball.
Yeah, I think volleyball is probably the best one of all. Thanks, Jim. Anything that you enjoy doing, I would say is number one. It's hard to, like I mentioned, motivation often comes after action, and it's hard to get excited about doing something that you don't enjoy doing. So if you're not somebody who wants to go lift weights and walk on the treadmill, that should probably not be your form of exercise. Ideally, something that's multimodal, right? Something that both helps with your resistance training, also helps get your heart rate up, and something that requires significant coordination. I know we often talk about the big movements classes that people will do, and anything that's using big muscle groups and requires some coordination, ideally that lets you socialize. I think there's some good evidence for racket sports like tennis and as being great for longevity, but anything that you enjoy.
Yeah, tell folks you don't have to go become a big bodybuilder and put on lots of big muscles, but it's a combination of cardio, resistance training, and good sort of stretching and toning exercises. And if you hit all 3 of those across your week, you're doing all the right things in terms of the data, what types of exercise will slow progression of disease. So you want to mix all 3 of those things into your week. And I encourage people 30 to 60 minutes of some kind of physical activity every day. And if you aim for 7 days a week and you get 6, then we'll forgive you. But, as one of my patients told me, she said, Parkinson's doesn't take a day off, so I can't either. So really think about it from that vantage, and how do you stay ahead of it?
We have a Rock Steady Boxing referral off Wendover Road, which is just a few blocks from here.
Bob and Donna, I'm gonna go. So now y'all have to go to all the classes, so y'all are there.
All right, it's a just workout. And a question about anesthesia. Somebody was told by a caregiver that a person with Parkinson's should avoid anesthesia because it accelerates Parkinson's progress. Is that true?
I wouldn't say it accelerates the disease progression over time, but often things like general anesthesia or even narcotic pain pills, they can linger and cause a lot of confusion and hallucinations. I've seen folks go in for a simple outpatient procedure that should take 30 minutes and they end up in the hospital for 3 days with post-op delirium. So it's just the anesthesia can linger. I think about the Parkinson's brain as just having to work twice as hard as it used to. And then you put extra stress on top of it and things can happen, but it's not going to permanently accelerate the disease. So when people have to have surgery, we go into it very carefully, but they can do it safely. We just kind of let everyone know that it may not be wise to do this as an outpatient. We may end up staying in the hospital for a day or 2.
I would say that that's another great reason to exercise, right? Is because if you keep your bones stronger by doing some moderate resistance training, you're less likely to break a bone if you do fall, and therefore you're less likely to have to worry about things like anesthesia. And it's a real thing.
Thank you for joining us tonight, and thank you very much, Nicole, for making the trek to Charlotte for this, and thank you to Dr. Iyer and Tom, and thank you all for being here.
Thank you. Thank you.
Bye, y'all.